Can you tell us why it is important for us to do this woman's trial? Why is it important for us to conduct this trial?
Postpartum hemorrhage is a major cause of maternal mortality worldwide. Every year about 500,000 women die of causes related to pregnancy and childbirth, and postpartum hemorrhage accounts for between a quarter and a third of those. Approximately 14 million women experience a postpartum hemorrhage every year. About 2% of them die. So this is clearly a major global health problem. But in fact, the interest in this trial came from the collaborators in the CRASH-2 trial. They said to us, there's two types of patients we see who bleed to death in our emergency department, and that's young men with trauma and women with postpartum hemorrhage. And they said, why aren't we doing a trial of tranexamic acid in postpartum hemorrhage? So when we looked into this, we found ourselves asking exactly the same question, that this was an important question that needs to be answered. Most of the burden of disease from postpartum hemorrhage is in developing countries, lower middle income countries, a big burden in Africa, and most of the patients die very soon after the onset of the hemorrhage, in the first few hours. So this is an emergency treatment for a life-threatening condition, just like CRASH-2. And so it makes good sense that we're answering this question.
Can you tell us, why do you think an antifibrinolytic such as tranexamic acid would be useful for women with postpartum hemorrhage?
Well, tranexamic acid could reduce blood loss in patients with postpartum hemorrhage. There's really good evidence that it reduces blood loss and the need for blood transfusion in patients undergoing elective surgery. Now, if it had the same effect in women with postpartum hemorrhage as it does in elective surgery, then that could be really important, because women with postpartum hemorrhage bleed to death. Tranexamic acid is something called an antifibrinolytic agent, and that means it inhibits clot breakdown. Basically, there are two processes going on, clot formation and clot breakdown. And tranexamic acid, an antifibrinolytic, inhibits clot breakdown, and so it helps clotting. And in women with postpartum hemorrhage, helping clotting could be a really good thing to do. So there's every reason to hope for benefit, but we don't know. We can't be sure that the benefits exceed the risks, and for that reason we're doing the trial.
Diana, in the protocol, the woman trial uses what is called a pragmatic trial design. What do you mean by that?
Well, lots of people mean different things by it, but here what we're meaning is that what we want to have is a trial that the results can be used in places where it's needed, where postpartum hemorrhage happens, in their usual clinical practice. So we want to be in a situation where the clinicians who are entering patients into the trials say to themselves, first of all, is it clear that tranexamic acid is going to work? We know it isn't clear because otherwise we wouldn't be doing the trial. Are there severe contraindications why we shouldn't be giving it? In which case, don't give it. Have we got a window in the middle where we're uncertain that it might help, it might not help? That's the time we need to do the trial in those sorts of patients. That uncertainty principle means that you're mimicking what really happens in real life, in real clinical practice, and that's why the results of the trial can then be used in those sorts of settings thereafter.
Diana, can you elaborate on the double-blind, randomized, placebo-controlled design that this study uses, and why we're using placebo in this study?
Yeah. There's lots of components to that, and I think the most important one there is randomized. What we want at the end is a trial that says, do we know whether the tranexamic acid helps women in this sort of situation or not? So we have to compare two groups, a group that have been allocated this active treatment and a group that hasn't. So we need to randomize, we need to allocate people by chance to create two comparable groups. That's the first step. Then when we're assessing the outcome of the trial, we want to do that without being prejudiced by already knowing what treatment the woman's had. So if you've got a preconception that tranexamic acid will really help, then you might be more likely to come up with the right answer, not to go into a hysterectomy early, to make some decisions as a clinician in that knowledge. So to try and not do that, we try and what's called blind the clinicians, the people who are assessing the outcome, so that they aren't influenced by knowing what the intervention was. And that's blinding. And sometimes it's called masking, but here we're calling it blinding. And sometimes the only person who's blinded is the patient. Sometimes it's the patient and the caregiver. In this sort of situation, although it's double-blinded, both of them aren't aware of what the allocation is. In fact, it's very hard to see how the woman, knowing what her treatment was, could really make a lot of difference. But it could affect the caregiver, the clinician. And then to help them to be blinded to their allocation, you, instead of just giving treatment and no treatment, you give treatment and a placebo treatment. Placebo is just like the active treatment, just like the tranexamic acid, but instead of it being openly that, it's actually something that looks like it, smells like it, tastes like it, packaged just like it, but isn't it. And so the person who's doing the assessment afterwards, or the person who's giving the care, doesn't know whether they've been given active treatment or placebo. It's perfectly ethical to give a placebo in a situation where you don't know that active treatment's going to work. And so this is a double-blind, placebo, randomised controlled trial, which is a mouthful, but actually broken down, each bit makes sense.
If a woman is randomised into this trial, I see from the protocol that she'll be given 1 gram of tranexamic acid or placebo, and then another gram later on, if indicated. Can you tell us why you've chosen a dose of between 1 and 2 grams for this trial?
A dose of 1 gram may stop the bleeding, and we hope that it will do. But if it doesn't and bleeding continues, then it's appropriate that we increase the dose by giving another gram. Now, this choice of dose is based on information on the pharmacology of tranexamic acid, and it's believed that this is a dose that will inhibit fibrinolysis. So we've drawn from the use of tranexamic acid in elective surgery, and this is the dose that they would commonly use there. So we hope that 1 gram will be enough. If the patient continues to bleed, a second dose of 1 gram, and that's the trial treatment that we're evaluating.